indeed for this very kind introduction, and congratulations on the highest quality of this meeting. I'm more than pleasantly surprised since I arrived earlier today with all those innovations and things that are in progress, and certainly it's very nice and very honorable to be working with you here at Onassis Hospital. Now, I have nothing to disclose. In the last years in the COVID area, TikTok, YouTube, and everything, we are all getting wiser because we hear many, many quotes from many people. Everybody wants to say his or her quote and uploads it on YouTube or wherever. Now, I heard a nice quote the other day. If you pray for rain, you got to be prepared to deal with mud as well. So this comes sort of in conjunction with prosthetic heart valves. The heart valve is a divine device. It's the rain. However, once a prosthetic heart valve is implanted, it's a foreign body. It will do its divine job. However, that will come at a cost. And the cost is, of course, complications, the mud. The valve may be dysfunctional, there may be dehiscence, endocarditis, PVL, which is essentially the subject I'm going to elaborate upon today, thrombosis, Pan's formation, pseudoaneurysm, abscess, just to name a few. And paravalvular leak is maybe one of the most important ones. Para comes from the Greek prefix, which means next to. And PVL is, I assume you can hear me, that's why you don't interrupt me. Okay, so PVL is abnormal flow through a channel between the valvular prosthesis and the valvular native annulus due to inadequate sealing. It's something that shouldn't be there. And PVL is characterized by inappropriate apposition of the prosthesis in the native tissues, and that this leads to an abnormal connection between the cardiac chambers. As you much better know than me, the 4 cardiac chambers are sealed tightly between them. Unfortunately, PVL is a relatively common complication of both mechanical and bioprosthetic valves, 20% in the aortic area and maybe twice as much in the mitral position. Factors predisposing to PVL development are technique, position, sewing ring composition. Causes include dehiscence, infective endocarditis, etc. Now, has been observed recently that the volume of calcium, when it reaches a threshold of 850 Hounsfield units, as measured with CT, is the best predictor of PVL in cases of TAVI valves. Speaking about TAVI valves, self-expanding TAVI valves are more prone to PVL than balloon-expandable ones, and the most overall common cause of PVL is endocarditis-induced dehiscence. Interestingly now, PVL can be seen without any definite signs of dehiscence, and this may be due to alteration of the normal geometry within the heart itself. Almost up to 20% of PVLs are seen in the immediate postoperative period, and most patients, fortunately, have small PVLs, and they remain asymptomatic. However, large PVLs are again fortunately seen in less than 1% of surgeries, and they can result in heart failure, hemolytic anemia, or endocarditis. Now, enough said, let's see some things. Is there a pointer here? There is, okay. Thank you. As I mentioned earlier, yes, excellent. As I mentioned earlier, PVL is something that shouldn't be there and connects 2 chambers. Now, this is one chamber. Here is the aorta, and the other chamber is the left ventricle. This is the prosthetic valve. This multicolored serpentine is flow of blood that goes to and fro, okay, when between systole and diastole, and this happened because the valve ultimately got detached from where it was initially placed. Now here you can see the arrow in the aortic valve area. You see this chamber, LV, is connected to the aortic chamber, and this corridor of contrast is the PVL. Now the same here, we have a TAVI valve here. You can see that there is a channel here, which is contrast. And when you see contrast connecting the left ventricle and the aorta, and having a strong hint from the cardiology department, the ultrasound department cardiology, then you must look for a PVL. And this is what a dehiscent valve looks like. In this scheme, you see stitches here have been disrupted. So this area shouldn't be like this. It should be like this, where the stitches are intact. And the result of stitches being broken here is this crescent-shaped area, which is contrast outside the mitral valve, the prosthetic valve, which is this, and this is the myocardium, where it was initially attached to. Now, first of all, a good clinical history, hemolytic anemia, heart failure, endocarditis, is what will give the referring physician, the cardiologist, the first hint that something's wrong. Next step, and it's an extremely important step, and this is the step that actually gives us the diagnosis, is echo. And 3D transesophageal echo is the gold standard of diagnosing a PVL. Now, my talk is mostly about CT, so slowly I will deflect into more CT images. So in CT, what we see is contrast material going from one chamber to the other, or even better, contrast material connecting two chambers. Let's see, I'll show it to you further down. Now, the problem with demonstrating a PVL arises when we don't know it. For example, on a daily basis, we see and read 5, 10, 20, I don't know how many, coronary CT angiograms. Now, those angiograms are automatically displayed for us to diagnose in the 3 elementary views. That's axial, sagittal, and coronal. It is extremely difficult and highly unlikely that we will diagnose a PVL in those images alone, even if we have the history and the hint from you. So we don't have any radiologists here, but the thing to remember here is that the only view that will demonstrate the PVL is the view that the radiologist himself or herself will create, and this is a true axial double oblique reconstruction of the data set. Now, someone will ask us, can MR do the same thing? Well, MR can be done, but there are too many dephasing artifacts. The 3 data set is getting better, but not at the same level of resolution as the CT data set. There are some sequences that show dephasing, and thus they are diminishing the quality. And however, we can quantify the regurgitation using phase contrast MRI. I think enough said. These are some technical aspects of us radiologists to know. What you should know is that when you refer to us a patient with, the question, is there a PVL or not, just please try to have your patient with low heartbeats. 60 is very good, 70 is acceptable. So in the 60, 70 beats per minute area. Okay, some images now. Now arrows here show where the paravalvular leaks are. We are in the aortic area on the left-hand side image and in the mitral valve area on the right side. This is before and after interventional cardiology corrected a PVL. Here is before, sorry. Okay, here's the PVL. And here's after correction with all those ambulatory occluders. Again, this is the PVL. Okay, again, the sine qua non is you see a contrast medium column connecting proximal and distal chambers. Okay, again, now this view here, see how nice the aortic valve and the mitral valve are presented. Yes, this is not a standard view for us. Okay, it may take a few minutes, and of course you have to know what you're doing in order to present to you this nice image, this nice view, so that we can perform, measurements on what dimensions the PVL has in order to plan your intervention. Again, see some measurements here, here again. I think we are at Onassis in collaboration with a certain company which makes 3D models of the valves and the PVLs more specifically. See here the PVL here, and I think this is the PVL here. Okay, I'm out of time, but I'm getting close. Okay, this here is a PVL next to the mitral ring. Oh, good. Okay, so the three most important things: history, history, history. You and us must have a high degree of clinical suspicion. It's one of the complications that usually or unusually arise when you have a prosthetic valve. With echocardiography, cardiology has first diagnosed what's going on, so we urge you to give us that piece of information because, as I mentioned to you earlier, even if we do double oblique images in all prosthetic valves, in any location, if we don't know where and what to look for, chances are that we may very well miss it. And I'm talking from personal experience, not others. In CT, what you have to look for is a contrast material filled channel in the paravalvular region that connects two adjacent chambers. Again, it's very easy to miss. And for radiologists who are not here, always use double oblique reconstructions. And this is the most essential part to demonstrate a PVL. Thank you so much for inviting me.
Dr. Vrachliotis, thank you for this enlightening lecture. I would like to emphasize that, of course, CT is an increasingly important imaging tool for the structural cardiac disease. Using echo, we can identify paravalvular leaks. Although, using the CT, we can have the access of for the procedure. We can have the right angulation for the measurement, and maybe this paravalvular leak is a little serpiginous, I can say. So I think this technique must be done in every paravalvular leak.
I think we do it. I think we do it. What we are asking you to do for us is tell us, because it's, I mean, it shouldn't be happening. But the truth of the matter is that it's extremely easy to miss, and this is not from personal experience only, it's in the literature.
Yes.
It's in the literature. So we have to abide by what the literature says. And since, this is a very, very nice and open
Exactly, and this is the point
here.
of having multidisciplinary teams.
Exactly.
Yes.
I'm telling you, and one day so let me just finish this. I got in the meeting, they had already started, and when I saw the name, I said, yes, I know that. And in front of everybody, I said, fine. Now, don't tell me, this is a PVL that we missed, which was, what had really happened. But the most interesting thing is that everybody was looking and was trying to find it, despite the double obliques, and we couldn't, because we didn't have the right guidance. Of course, it was not a huge PVL like the one I showed here. It was something small, but still. And the other thing is that, and Dr. Vartela, you suggested that some time ago when you came from, your sabbatical in England. Yeah, we have to sit together. Radiologists don't know cardiology, and radiologists don't know cardiology. So unless we sit together and, get things.
And we sonographer, like the sonographer, we feel very confident for all these paravalvular leaks. And sometimes we miss some things on that paravalvular leak that we are studying. So that's the reason we have to ask for a CT.
So we're happy if we're getting our collaboration.
Okay, so now we have a radiologist, we have an echocardiographic specialist, and we have a CMR specialist. This is Dr. Nyktari. She's hybrid. Dr. Nyktari, can you?
Yes, I'm connected. Okay, good evening to all.
Excellent, excellent. We, as interventional cardiologists, we don't communicate a lot with CMR specialists, apart from certain, let's say, quantification purposes. We want to be very thorough in ejection fractions, in volumes, or in regurgitations. So do you have any other idea? Do you think that there are issues that you can help us more identify problems in structural heart disease?
So to begin with, I think there is a lot of improvement the last couple of years regarding the elimination of artifacts that have to do with the metallic rings and all the prosthetic material you get into the heart. So just to make a comment, BSSFP, CNS, which are the traditional way to visualize the paravalvular leak, is the worst way to check it. So now with the 4D flow technique, we can actually mimic the three-dimensional transthoracic echo. And despite the fact we have the metallic artifact in situ from the ring, usually, or the stent segment of the valve, we can actually visualize the paravalvular leaks. So I'm not sure if I can share my screen. This is a present to Dr. Vrachliotis, because he had asked me if I can show a picture showing an MRI image that has depicted the paravalvular leak. This is not mine, but I can show you how it is. I'm just trying to find out whether I can share my screen.
Μπορούμε να βοηθήσουμε,
Yes.
κύριε Νύκτερη, να κάνει share.
Yes, that's fine. So this is from a publication. I'm not sure it's showing. I'm not sure whether you can see it.
Well, no, it's not, but is it possible? Yeah. Yes, we see it.
Can you see it? Can you see that picture?
Yes, yes.
So you can see now the metallic artifacts from the rings in situ, but despite the material, you can also see the red jet projecting next to the metallic artifact. So yes, if you ask me whether MRI can be useful, yes, it can be, but with the newer techniques, the more novel techniques, just like 4D flow, which of course are time consuming, but we have a new under development sequence that we can take this image in 6 minutes. Unfortunately, we don't have referrals yet. So you are very welcome to refer patients, and then we can actually compare the findings with CT and
ultrasound.
Yes, and CT. Dr. Vrachliotis, we can actually take comparable images with MRI with a new sequence named BOOST. And this is a research proposal. We can actually get the sensitivity and specificity of detecting and quantifying such leaks using 3 techniques, and using TOE as a standard, gold standard.
Excellent. So this is a real-time heart team discussion. So thank you for that, Dr. Nyktari. Maybe we will continue the discussion of the heart team on Thursday afternoon. So good. So we have to proceed now with the live in a box after the